Good morning, good afternoon, and good evening. Welcome to everyone to join the launch of the Interprofessional Midwifery Education Toolkit, and particularly the Essential Childbirth Care course. I'd like to welcome everyone for joining us. My name is Anshu Banerjee. I'm the Director for the Department of Maternal, Newborn, Child, Adolescent Health and Aging. And we will just highlight quickly what the program is going to look like for today. So first of all, we're going to have some opening remarks from Dr. Tedros, who is our Director General for WHO, as well as from the Right Honourable Amanda Milling, who is a Member of Parliament and Minister for Asia and the Middle East at the UK Foreign, Commonwealth and Development Office. After that, we'll have a presentation by Alison Moran, who will highlight what the Essential Childbirth Care course is looking like. After that, this will be followed by a panel discussion, which will be facilitated by Fran McInfield, who is the Technical Officer for Midwifery in our department in WHO. And finally, we'll have some remarks and reflections from our main partners. Having said that, I'd like to introduce Dr. Tedros Ghebreyesus, the WHO Director General, for a couple of opening remarks. There's no sound.
Course available in the Excellencies, dear colleagues and friends, I'm delighted to welcome you to the launch of the WHO Essential Childbirth Care course, the first course available in the Interprofessional Midwifery Education Toolkit. The contribution of midwives to the lives and health of women, newborns, and their families is immeasurable. And yet, the world still needs another 900,000 midwives. As we work to support midwives to provide high-quality care, it's time to rethink the way midwifery is taught. Unfortunately, health workers, including midwives and nurses, can often be the last to be included when new WHO recommendations are shared. This is why, as we launch the Education Toolkit today, you will hear from the midwives who supported WHO in developing the course. They will discuss a variety of critical issues, including the importance of providing care in a respectful, compassionate way that supports the lives and health of women, newborns, and their families. The activities in the toolkit are designed to be interactive, challenging, and fun, including the one addressing the barriers to quality care arising from gender unequal institutionalized hierarchies. I urge all of you to share and use these materials widely. Thanks to the many who supported this effort, including the Foreign, Commonwealth and Development Office of the United Kingdom. I thank you.
Thanks very much, Dr. Tedros, for those opening remarks. Next, we'll have some remarks from the Foreign, Commonwealth Development Office Minister, the Right Honourable Amanda Milling.
I am proud the UK has strongly supported this midwifery education toolkit by providing approximately £250,000 worth of funding as part of our commitment to end preventable deaths of mothers, babies and children. It is an essential step in improving care for women and babies around the world. Every day around the world, 800 pregnant women and 7,000 newborn babies tragically die. These deaths happen to the most marginalised and vulnerable in the world. We know that trained midwives can help prevent maternal and newborn deaths from happening. They provide a range of essential services for women and babies, including family planning, antenatal care, and newborn care. And they promote kind, respectful care. I commend the World Health Organization for the creation of this important toolkit and hope that it will act as a tangible step towards reducing preventable deaths globally.
Thank you very much, Honourable Minister. Next, we will move to a snapshot of what the Essential Childbirth Care course looks like. And I'd like to hand over to Alison Moran, who is our unit head for maternal health. Alison, over to you.
Thanks very much, Anshu. And great to see everyone. Thank you so much for joining today. So I'm just going to give a quick overview of the education toolkit and talk about how the essential childbirth care course fits within the toolkit. So I don't know, Fran, if you can pull the slides back up, but just to say that the midwifery education toolkit includes a variety of different courses. And today we're going to be talking about one of the specific courses on the essential childbirth care course. So each course includes both facilitator and learner guides. And these pre-course materials are available online and will be available well in advance, including all the evidence in the videos and the references to other training courses. The courses can be done in educational institutes, and that's needed for simulated practice and also for the mentor clinical practice to ensure that there's a blended learning approach. But the online materials can be done well in advance so that staff do not have to take a lot of time out of their regular work, but can try to fit the work within their existing work time. We estimate that it will take about 5 days for each of the courses within the toolkit, but it's modular so that the different courses can be done at different time points throughout the day, such as over lunch break or in your morning break, so that it can be done within your regular workplace. There are really two key principles that underpin the toolkit. The first is that everything within the toolkit is based on WHO evidence-based recommendations and follows a midwifery model of care, so that we really look at following three healthy women and their babies in a continuum throughout the course of their pregnancy and their birth. And throughout the process of the course, we get to know their birth companions, their family circumstances, their cultural and emotional needs, and also develop empathy for the women and their babies so that it really follows a midwifery continuity of care model. So you'll see here in the orange boxes, there are 4 different courses within the toolkit: antenatal care, childbirth, postnatal care, and sexual reproductive health, which includes family planning, medical, and comprehensive abortion. And there are also several cross-cutting courses on respectful care, perinatal mental health, and midwifery leadership. The respectful care course has been drafted and is going to be pilot tested soon. And the midwifery leadership course is in the process of being co-designed in 5 countries by midwives themselves. And we'll be starting the perinatal mental health care course quite soon. I also wanted to note that all the courses link to other WHO courses and materials, which you can see in that pink box in the bottom. So including linkages to training sessions and modules on emergency obstetric and newborn care, maternal death surveillance and response, violence against women, and others, as you can see on the slide. But today we're going to be focusing on the essential childbirth care course. So just again to reiterate that this course is a derivative from other WHO recommendations with a strong focus on the intrapartum care recommendations, as well as really using the point of quality care improvement, or the POQI, as well as these other documents that you can see here on the screen. Next slide, please, Fran. Thank you. And I just also wanted to reiterate that the toolkit and the essential childbirth care course is grounded in the Quality Maternal Newborn Care Framework, which was first published in the Midwifery Lancet series in 2014 and further published in WHO's Framework for Action for Strengthening Midwifery Education. And there's an activity within the course that talks about how to use this framework to ensure there's a joint understanding on the basis of how to provide quality midwifery care. Next slide, please. So you may ask, why do we need this course? Well, we've had over many years requests from multiple countries for how we can really ensure continuing professional development materials for midwifery using the midwifery model of care for healthy women and newborns. So this responds to that gap in evidence about how to provide informed midwifery education materials and ensuring that WHO evidence-based recommendations are in the hands of these practitioners. It also really uses a blended learning approach and tries to minimize the time away from clinical care through online materials and other opportunities, which we'll hear about when we get to the panel. And really shifting from a didactic training of trainers approach to modern, innovative adult education for the 21st century and beyond, as well as I said, links to relevant other courses and resources so that they're right within the midwife's hands. Next slide, please. So why is this important? This is important for several reasons. The toolkit and the essential childbirth care course can be used for continuing professional development for all appropriate providers who provide midwifery care, including nurse midwives, OBGYNs, pediatricians, and many others, depending on the context of your health system. And it also provides an opportunity for contributing to pre-service education, as well as for direct entry midwives and for others who are responsible for ensuring respectful care and upholding the rights of women and newborns. Next slide. So now I'm going to focus a little bit more on the essential childbirth care course and how it's organized. There are 5 modules, both in the facilitator guide and the learning guides. So there's an introductory module, a module on the first stage of labor, a module on the second stage of labor, third stage of labor, another module on immediate newborn care, and a final module on appropriate and respectful referral. So as you go through the materials, you'll see there's not much difference between the facilitator and the learning guides, but that's because this is a peer-to-peer learning process, and often the learner may know more than the facilitator who is there to take them through the evidence. The materials will be available freely online, and you can see the link there on the slide. And I just wanted to also note that there will be a pre and post test for knowledge within each of these modules. And that's really to help the learner understand how much he or she has learned throughout the process. The assessments are not supposed to be a criticism, but really help the facilitator know what they need to focus on during the course. Slide. So the essential childbirth care courses and the rest of the toolkit is very much based on the WHO quality of care framework for maternal and newborn care, which I'm sure many of you are familiar with. And this framework equally positions both provision of care as well as experience of care. And so within each of the courses, the learning outcomes include outcomes for both the provision of care and experience of care. And this is really important because by the end of the course, learners will remember about the standards around experience of care as they go through each of the different exercises and activities will help reinforce the importance of that element as equal to the provision of care. In addition, the module of the course includes action plans from Laerdal Public Health. And these action plans can be used as job aids for providers and also shared with women and families as part of the learning process. Next slide. And then finally, you will see as we go through the panel, the course includes a range of interactive activities such as role plays, teamwork, treasure hunts, really interactive ways to learn about the different pieces of information that are included in each of the modules. And as we go through the next panel, you'll hear more about these different activities and how to use them. So with that, I'm going to turn it back over to Fran, who's going to help moderate the panel where we talk about this in more detail. Thanks, Fran. Over to you.
Thanks, Alison. Just for a really great snapshot. Of course, there's a lot in the course. So now I'm going to welcome the most amazing group of panelists, all of whom who've really helped us hugely to bring this together. You can see Sheena Curry, Pragati, Sharma, Indi Kaur, Rashmi, Aradia, Kavri Mehra, Florence West, Margaret Piri, and Sarah Barziv. And I want to thank them all hugely because we could not have done this without them. And Fatima, sorry, your photograph is just hidden for me. I'm Fatima Gohar from UNICEF, making sure we don't forget the newborn, of course, as well. So they've just got a few things to let you know about this, about the essential childbirth care course, and they've all been involved. This is not any one of us sitting here doing it alone. We've all contributed our experiences and our thoughts and our fun actually to doing this. So I'm going to start by introducing Sheena Curry. So Sheena, if we can see you on the screen. Sheena is the Senior Maternal Newborn Health Advisor and Midwifery Educator at JPIGO. Anyone who wants to be educated as a midwife needs to know Sheena. I would doing it all over again. So Sheena, if we can see you, I don't know that I can see you, I hope others can.
I hope so.
Good. My question to you is, you have so much global experience in midwifery education, and you know about many, many courses. Do you think we need the childbirth care course? And what is it that you think is that different about it? And what is it that really gets to you about this course? Why do you think it's important? Thanks.
So thank you, Fran, and greetings, everyone. It's very exciting to see the Essential Childbirth Course, or ECBC as we know it, up and running. We all know that the guidelines and recommendations from the World Health Organization are a great resource, but ensuring this evidence is put into practice is a challenge in many settings. Dr. Tedros and Alison also mentioned this. Some recommendations, such as companionship in labour and birth, have been around for 10 years or more, but we're finding that midwives and others caring for women, newborns and their families do not yet have access to these guidelines, or when they do, they may not have the confidence or ability to put this guidance into practice. So in line with effective educational practices and participatory learning, in the ECBC, we are not only sharing updated information, learners have to actively find the recommendations and evidence through an activity called a treasure hunt. The topic on the slide is really a great example. I'm sure you know this, that having a companion improves birth outcomes for women and newborn, as well as the overall birth experience. And as midwives contribute to improving the quality of respectful maternal and newborn care, including midwife-led care in some settings, such as Afghanistan and India, a first step is knowing where to find the evidence, which is the treasure. They can then be explicit and deliberate in taking this evidence into making decisions about care in consultation with the woman. I first used the treasure hunt in a workshop with midwifery faculty in Myanmar, where JPIGO were supporting the government to strengthen midwifery education. It can be played as a game by individuals or teams with chocolates as a prize if you have them. But finding the treasure really empowers and capacitates the midwives, the facilitators, the learners, and targets the larger goal of improving quality of care. And it's great to see how this activity is now being embedded across the Toolkit courses. Thank you, and I hope you may find the treasure. Thank you, Fran.
Thanks, Sheena. That's really helpful. And I love the fact that this was your idea that you brought to us and you'd worked on it, and we were able to incorporate it in here along with so many of the others. So now I want to take you to what 3 of the midwifery educators in India who helped us co-design this. I want you to just watch a video, very brief video on what they thought, because there's nothing more important than what they think. They're the ones who are going to go on to teach this. So Tala, if you could put that video up, thanks. So this is Ruth Joshila speaking, followed by Shital Sampson and Amit.
What I like most about the project is that it has introduced me to wealth of knowledge and evidence that is available in midwifery, which has woman-centered approach. The program, it has enabled critical thinking in me through the exercises, especially the Pocky cycle. It helped me to analyze things in a systematic way in the light of WHO recommendations.
What I would like to say about quality of this essential childbirth care course is it is woman-centered and it is mostly based on the philosophy of midwifery model of care, and evidence-based practices are also included in this, and many innovative learning teaching methodologies are also very useful in this.
What I liked about pilot testing the ECBC course was the access to wealth of evidence-based information. The point of care quality improvement exercise ignited a whole lot of critical thinking. This is tremendously empowering.
Thanks for sharing that, Olive. And before we go further, I just want to invite 3 of the people who supported me and us and all of us together in facilitating those courses. And the very first time we did the co-design, it was in Gujarat before COVID, and it was face-to-face. And it was like the first time we'd taken this out. So Pragati Sharma, are you there? Could you just tell us in a minute just what you thought was the most important thing about that face-to-face learning for all of us. Thanks.
Yeah, hi Sam, thanks. I think when we went to Gujarat in 2019, it was a whole new setup, and the students there in the already existing College of Nursing were very excited to do this. I think what they really enjoyed was the treasure hunts, like Sheena mentioned, because initially they were not aware of, I mean, even if they were aware of evidence, they didn't know where to look. And I think that exercise gave them a point of reference on where to find the evidence, and in a fun way. So I think that was the part that I remember the most.
Thanks, Pragati. And I remember that the younger ones went straight to their iPhones and the older ones went straight to the hard copy. It's like something for everyone. Thanks a lot. And it was great being there with you, and your facilitation was really brilliant. So now, Rashmi, as an obstetrician from Ledal Global Health in India, thank you for joining our midwives panel. But when we did the online version, because we continued during COVID, and your passion for this was just infectious, as you can hear from those women. So what was it you felt that really stood out about the co-design?
So when the ECBC course was being designed, it was supposed to be a face-to-face kind of a course. But when we tested it in India, because of the COVID pandemic at that point in time, we had to do it virtually. Now, although the package or the module was developed for a face-to-face training, it was easily adapted by the facilitators or the learners to different situations, like, which actually made it challenging for them, because it was not a face-to-face anymore, but it was virtual. But then they were able to come up with so many innovations, and the enthusiasm, of course, from the participants was so much, because they were able to read the whole module, and they were able to understand it so well, and they were able to do this activities virtually with innovations from themselves. For example, they did this role play with 4 different people in 4 different places, but then spotlighting them on Zoom, and it sort of came together as if it was real. And similarly, simulation was sort of added to this one, and simulation was also done virtually with different people in different places. And the kind of learning that came out of it was immense, and the learners were able to adapt it to their own situation, which made it actually come alive, and it didn't really feel as if it was not meant to be a virtual sort of a training course to start with. But I think that is the best part about the ECBC course. Yeah.
Thanks, Dr. Rashmi. And it was just so wonderful to see them take that energy themselves and adapt it, because they wanted it. But it was also a big lesson for COVID, and really for people in very remote areas who cannot come in all the way, perhaps, to a facility for training or whatever, that we can share it that way. Your help on that was just tremendous. And then Indy Cow, are you there? Can we see you? Because you've taken this forward in Fernandez Hospital, which is funded through WHO through the National Midwifery Program in India. And India, what do you feel has happened since the course?
A friend, it's been over a year, nearly over a year now, and I see them develop and using the POCI cycle. It's challenging, to have practices that may not be evidence-based, but they're using what they've learned, and they've been empowered and using the POCI cycle to change practice. And I can see the confidence growing. And the treasure hunts, where to look for evidence. And now they're actually using these resources in their training of the midwives in India. So it's been amazing, and it could have come even sooner. I'm so happy about that. Thank you.
Thank you so much, India, and your leadership in making this happen and actually taking it back into the clinical area in Fernandez Hospital and seeing how it's been used. So it's not something that they just do and listen. It's actually changed their behavior when they go out to care for women, newborns and their families. And that's just very good to know that things are moving. So thank you so much to all of you for all the work and the co-design in India. We learned so much from you and from the women who did that with us. So thanks. And now I'm going to move to Kaveri Mehra, who many of you know. Kaveri is currently working in Vancouver in the University of British Columbia, but she's also been really taking us through how we incorporate respectful, compassionate care to really humanize the way we provide midwifery care. So Kavri, if we can see you as well, what is the, hi Kavri, good to see you. I know it's very early in the morning for you, thank you. What is the activity that you felt has kind of made a big change here in terms of getting this respectful care from an academic issue into a personalized, behavioral change?
Thank you so much, Fran. I am particularly excited about the teamwork activity. We know there are gendered issues. We know there are power-based issues because of the hierarchical structure that we work in not just areas of care provision, but also in different areas, including policymaking. And this can often come in the way of care provision. We hear stories of how care providers higher up in the hierarchy bully care providers much lower to them. We hear stories of care providers losing compassion and how disrespectful communication can often become team culture. So we have been very smart and we have carefully designed this teamwork activity for interprofessional teams where they look at a scenario and they try to understand how all of them can come together and whether they are empowered enough to provide respectful care. For example, in this slide, you are looking at the scenario of Meena, who has come to give birth, and she's 21 years old and she's not married. This is her first baby. And we further learn about Meena's story, and with her, a birth companion, Priya, arrives, who's her aunt. So it's the people who are arriving together, who are care seekers, and the team members like the midwife, the nurse, cleaner, obstetrician, pediatrician, the laboratory technician, others, everybody is important. And we want to understand if everybody is empowered enough. Do they feel empowered to provide respectful care? So when you see this activity, it's going to address this sensitive issue because language and vocabulary becomes important in acknowledging these issues, to raise it, to address it. This is going to come to your aid, and I hope this teamwork activity empowers you to provide quality and respectful care, which has been further adapted into a power walk activity in the Essential Respectful Care course that is coming up. Thank you so much, Fran.
Thanks, Kavri. And I think it is fun to see people acting, the obstetrician might be the cleaner, the midwife might be the manager, and just to feel what it's like and to understand how they come together. This is also an activity that came out of the Nepal Safe Motherhood Project many years ago that we've adapted here. So everyone's been bringing their experience. But thank you, Kavri, so much, and for all your work on respectful care right the way across this course and the respectful care courses. Brilliant. So now I'm going to go to Fatima Gohar, working with UNICEF, a midwife. So if we can see you, Fatima. Now, Fatima, people have already mentioned the POCI, but could you explain what that is? And I know that every time we talk about it, you come up with an idea, you come up with something because you're experienced in facilitating that. And that we've included the newborn, of course, is Meena and her baby and her companion. So I've just put the POCI slide up there. Thanks.
Thank you so much. Thank you. As all our other colleagues already spoke about the importance of the toolkit in itself, because the toolkit will help us, if it is being implemented the way it should be, will help us will give us triple return in maternal mortality reduction, neonatal mortality reduction, and also stillbirth. But it will not come on its own just by teaching. And that's where POCI, or point of care quality improvement, comes handy. And that's why I'm really excited about it. And as Deming said, variance is the enemy of quality. And to maintain the quality, to ensure the quality, we need, it's a iterative process. So the POCI basically, which is point of care quality improvement, helps us to identify gaps in the care. And that needs to be done in a multidisciplinary way, the way just Kavri mentioned, because quality is everyone's responsibility, not by just saying, but doing things. So you identify issues together, and then you analyze the issues together, the problems together, and then you make some goals for it, how to overcome those those gaps which you are seeing in the system, which are hindering either provision of care or the experience of care. And then you come up with the change ideas that, okay, this might work or that might work, in a consensus building way. You choose the change ideas, you implement the change ideas, and then you see that if your change idea is working towards your goal, if it is not working, you tweak it or you abandon it, and then you go through the process. But if it is working, you sustain it. And then you need to have those mechanisms in place. So that's where team building plays a crucial role, and it's not just a responsibility of clinicians, but from administrator to the guard and housekeeping staff as well.
Thank you, Fatima, very much. And for the listeners, each of the participants develops a plan as they go through each activity. By the end of the course, they have a really good point of care quality improvement plan for themselves and their team. So when they go back to their clinical area, they know they've got ideas, they've been encouraged and supported to implement this. But Fatima, your support to the POCI and the newborn part has just been fabulous. So thank you, really thank you. We look forward to taking it with you in Africa with UNICEF also. So thanks. Now I'm just going to move to Florence West. Florence is normally at ICM, but she's joined us for a couple of days a week for the past few months to really help us move forward. So Florence, you're a very, very experienced midwifery educator with a PhD in midwifery and a lot of international experience. And what is the recommendation that you think, or the activities that have made, that you would pick out here to talk to about today?
Thank you, Fran. I hope my audio is okay. Thanks to all the speakers before me. I don't know how I can follow you, but I, as an educator, it's really hard to teach continuity of care in areas in which continuity of care is not yet fully implemented. So the WHO recommendation for continuity of care is really exciting to see in the ECDC, and we're doing that through scenario-based learning, introducing learners to 3 women and their newborns throughout the whole suite of ECDC resources. And so the learner and the facilitator also will get to know these women closely from their pregnancy through their intrapartum care and postpartum care. So we're doing our best to stimulate continuity of care in the ECDC by really clear character definitions and design of these women, so you can feel really, really close to them. And while doing that and presenting these women in different scenarios, we really hope that that learners can experience humanized, respectful care of these women and their newborns, and appreciate the benefit of continuity of care through the whole reproductive cycle. As my previous speakers have said, maintain the quality of care framework, the POCI, treat women with respect and dignity, emotional support, and provide equal emphasis to the provision of care and the experience of care. So I think learners will really feel connected with these women, and it'll help their learning process and provide evidence for the recommendations. It's very I'm very enthusiastic about that.
Thanks, Florence. We've put up the simulated practice slide just to show that we know that Mina's baby is called Arush, and again, as you've said. Could you talk just a little bit about the mentored clinical practice and what we mean by that? Because we know in about half of clinical education sites, it's actually just theory, and there isn't really any clinical work going on because they're so far perhaps from a practice site.
Yeah, absolutely. So I think this is a really important aspect to include in ECDC, is the mentored clinical practice, and we provide in the ECDC guidelines for how to be an effective mentor and what are the responsibilities of the mentee in that relationship also. And so we're encouraging learners to have some mentored clinical practice in a health facility, to work together with clinicians and really encourage the continued professional development process post initial training. Yeah, as we know, that's really essential to quality of care.
Thanks, Florence. And we know it's difficult, you know, the course does need this clinical practice, and it will be up to the Education Institute to organise that. We can't say when you will do that. So there is an initiative needs to be taken also by them. But that's great, Florence, and thanks for all your support. So now I'm going to go to Malawi, where we have Margaret Piri. Now, Margaret, if we can see you, that would be great. If we can't see you, we just want to hear you. We've got your lovely photo here. Because we've already started early discussions in Malawi about how we can move this out, along with 4 other countries. But could you just tell us what you think is going on in Malawi in terms of the next steps and how we look forward to implementing this at countries? Thanks.
Thank you very much, Fran and all. Hope you can hear me, although I'm not videotaped.
We can hear you. Yeah.
I just want to share with you and all about how excited and ready we are as Malawians at the prospect of piloting this initiative in our country. Let me just assure you all of the potential for success of piloting this initiative at one of our renowned higher learning institutions called Kamuzu University of Health Sciences, which actually offers the infrastructure to operationalize this project, as the institution is a renowned and functional WHO collaborating center for interprofessional education and collaborative practice, not just for Malawi, but for the whole African region. Also, the government of Malawi, through Ministry of Health, has just officially launched the midwifery-led care ward model, spearheaded by this very same institution at one of our busiest BMOC health facilities, which has an average deliveries of 200 babies per month, translating to 2,400 per year. Technically, we have the capacity to implement this initiative at this very same facility, which has a total of 23 midwives who are professionally trained and who ensure continuity of care and influencing innovative improvements at a point of care, as has been shared by other colleagues. Lastly, there's a great political will by our government to strengthen midwifery and interprofessional education and collaborative practice so that we can make a difference in the area of midwifery contribution. All I can say is come to Malawi to share with us this dream of success. Thank you very much for listening.
Thank you, Margaret. We'll be relying on you to help us take this forward, and the fact that Kamuzu University of Health Sciences is going to spearhead this in Malawi and in the Africa region as an interprofessional collaborating centre is fabulous, and having you there as our person to take it forward is, we know it's going to work, we know it's going to happen. So I'm really looking forward. We've been saying after the launch we'll get moving on it, so we're very much looking forward to that. Now I have to say my next speaker is Sarah Barziv. I'm very sorry to say she's been on a flight to Australia for the first time in 3 years because of COVID to see her family. So poor Sarah has been traveling and her flight got stopped for 30 hours in an airport, so she couldn't join us today. But this is the question that I said I would ask her, that with all the wonderful global work that UNFPA is doing, and they're doing so much to strengthen midwifery education, how is the ECBC and the toolkit going to be useful to her? And this is what Sarah said. So I'm quoting Sarah. I'm sorry she can't join us, but I'm really pleased to hear that Sarah's already planning to integrate these courses, modules of the courses, videos from the courses, activities into their direct entry midwifery curricula, that they're developing a global version and a new 18-month updated version of the midwifery curricula. And as she says, they can select these modules and activities and adapt to the needs of the different countries and the different students. And she says it's been great working with and learning from multiple partners on developing this. And so I'm going to stop there and just thank this panel, because everyone on the panel, plus others, I have to say, who many of whom will be on the call, have just helped us so much. We couldn't have done this without any of you. And when midwives get together and others like Rashmi and obstetricians and pediatricians and social scientists, and we put our heads together and listen to what women need, we can really come up with something that seems to be really valuable for women. So now I'm going to hand over, because very excitingly, we have Elisa Roma from the WHO Academy, and we're going to take parts of this toolkit that don't need face-to-face. So the videos, for example, the treasure hunts and some of the other bits that are just for online learning. And we're developing, the Academy is supporting us to develop an online self-directed course. So Elisa, if you could just show your video of the future. And this is one of the video activities that we haven't shared yet, but you'll see they're in the face-to-face, but you can also do this yourself online. So over to you, Elisa. Thank you very much for the Academy for joining us.
Thank you, Fran, and thank you everyone, and welcome to see this activity. Let me just share my screen, so I will be able to show you one lesson from the online learning version. So it's module 1 in the first stage of labor. And this lesson is a video analysis entitled Initial Assessment in Labor. The learning objective is we would want the learner to be able to apply the recommended practices from WHO during women's initial assessment in labor. In this video, in this activity, we have embedded, thanks to Global Health Media, one of their video initial assessment on labor, and we will ask the learner to share their thoughts through some questions. So I'm going to play the video separately, just for a matter of for audio. So normally it is embedded in the lesson. So let me just play 1 minute of this video for you.
Initial assessment of a woman in labor. When a woman first comes to you in labor, your immediate responsibility is to find out whether her labor is progressing normally or if there are any worrisome signs. If any of these signs are found, it is safest to transfer the mother to a facility that can handle complications and perform cesarean sections.
Elisa, we can hear it, but we can't see it moving. Is there any way to actually play it so we can see the video itself?
You cannot see the video?
No, we can hear it, but we can't see it moving. Oh. I don't know if Tala is able to play it.
Let me just...
Sorry, we kind of thought you were waiting to click the button.
How about now? Can you see it?
We can see the first picture.
We'll show how to...
We can hear the speaking, but we don't see the video moving.
Okay.
Maybe you could click the button in the middle.
I can play I can play it in the lecture then. So let me try again.
Sure, thanks.
Sorry.
Now I think it's moving now. Yes, that's good. Thanks.
Initial assessment of a woman in labor. When a woman first comes to you in labor, your immediate responsibility is to find out whether her labor is progressing normally or if there are any worrisome signs. If any of these signs are found, it is safest to transfer the mother to a facility that can handle complications and perform cesarean sections, unless the baby is about to be born. This video will show how to assess our laboring woman and the signs that indicate the need for transfer. Start by gathering information. Help her feel comfortable by listening carefully, answering her questions, and treating her with respect. Check her antenatal record for any problems in her pregnancy and her HIV status. Ask her when strong regular contractions began.
Sorry, I'm going to stop the video here. It's quite a long video and we don't have the time, but I just wanted to show you the analysis and the self-reflection that follows after watching the video. The learner will be prompted to answer some of the questions. For instance, what is the new knowledge for them in the video? What skills and practices displayed in the video differ from their current practice? And which midwifery care provider behavior displayed in the video are different for their current practices. So they will be prompted to reflect on their current practices. The learner will be able to save their answers and download them in a PDF format, and then share them in discussion forums and in Zoom call. They will still also be part of this module, of this online learning experience. And the lessons end with some key learning points. We are very excited to launch later on the year this online version. And thank you, Fran, and everyone for giving me the opportunity to show this.
Thank you very much, Elisa, and thanks for supporting this project so much. We'd now like to go to a few reflections from our main partners, and particularly just to hear in 2 minutes from each of them what their reflections are on this toolkit. I would like to kick off with Harriet Naiga, who's a ICM Young Midwife leader. And Harriet, could you share a little bit your reflections on this toolkit? Harriet, you may be on mute. Maybe while Harriet sorts out her IT issue, we'll go to the next person, and that will be Dr. Megan Etiebet from Merck for Mothers. Thank you very much, first of all, for your support to the midwifery agenda and for supporting the toolkit. But maybe you'd like to reflect a little bit on what you heard today.
Thank you so much, Anshu. It's been an honor and a pleasure, to be part of this movement. I think everybody can sense the excitement that the toolkit has generated, across. I think there are over 2,000 midwives that registered for this course. So we are just, excited to be able to bring, the resources and the experience of the MSD for Mothers partners to this work. I wanted to say something, and we've worked on many collaborations with you and WHO, Anshu, and we all know that the toolkit, policy is not enough. We need to make sure that these tools get into the hands of people, midwives who need them, and we need to ensure that policy is translated into practice. And that just doesn't happen by itself. It needs work. It needs people pushing to change structures and systems. But I think it also requires us to work smarter and make sure that we're leveraging, commitments and capabilities that we've built across the healthcare ecosystem. For example, the work that we've been doing to improve and embed quality with other providers, including at private sector facilities. Dr. Tedros mentioned, we need, I think he said, over 900,000 new midwives in order to meet the gap. We're going to have to bring everybody to the table in order to fill that gap. And I just wanted to share, some of the exciting work, happening in India around these types of collaborations to drive this toolkit, into facilities so that they're used, with mothers. And that's some of the collaboration that MSD for Mothers is having, both with the Astrika Foundation and White Ribbon Alliance India, where putting the toolkit in the hands of professional societies so they can spread them across their network. Again, it doesn't make any sense if it's sitting on a shelf somewhere. Leveraging digital learning platforms, which we learned, worked really well during COVID, and another sign of, we can build for resilient health systems. Translating it into local languages and creating, quality circles so people who are using the tool can talk about it and their learnings from it, and everyone can support each other. The last thing I want to say, which I know sometimes people think is a dirty word, is incentivize. The system needs to incentivize people using this toolkit, and they need to make it easier, not harder to use it. And for that, I want to link to another collaboration we've had with White Ribbon Alliance, where in their Midwife Voices and Midwife Survey, which surveyed over 50,000 midwives, their number one demand was pay us the value that we are providing to society. We are not valuing the work of midwives. We're making it harder to do their work. We need to make sure that we're remunerating them appropriately. And like this toolkit is doing, providing professional and leadership opportunities, for their growth. And so that's one of the things I really hope that as an ecosystem, we can work on together to make sure that the critical work that midwives do is being valued.
Thanks a lot, Marianne, for those comments. I'd like to move to Sarah Thompson, who's the lead specialist for health and SRHR for CEDA. And in view of CEDA's strong support for midwifery, maybe you'd also like to reflect a little bit on what you've seen and heard today.
Thank you so much, Anshu. I would love to. Thanks for this invitation. And I just want to also, CEDA has been a part of this process, and I want to convey to you, my colleagues have mentioned that it's been a very collaborative, inclusive, and interactive, and even fun exercise. So thank you so much. I'd like to start with a personal reflection on this. 22 years ago, I went through a pregnancy and delivery here in Sweden, and I was accompanied at every step of the way by a midwife, not an obstetrician. Both my partner and I felt listened to, respected, and safe during the whole process. And I tell this story because it is the reality for the majority of women who deliver a child in Sweden, where our maternal mortality rate, as you may know, is around 4 in 100,000. And where we've had regulations for midwifery for about 300 years. Today, Swedish midwives provide over 80% of sexual and reproductive health services in Sweden. So the child that I gave birth to in 2000 was able to visit a midwife at a youth center when she was experiencing dysmenorrhea as an adolescent. And later, if she needs access to contraceptives, STI testing, or safe abortion, she will be able to visit a midwife for these services as well. And I want to pick up on something that Marianne said about the unfinished business. Advocacy for midwifery as a profession is still very much needed. Midwives are essential, as we all know, to strong and resilient health systems. But to be able to do their work, governments need to invest in them, their education, and their working conditions. They need to be licensed, regulated, and fully integrated into health systems, and working, as they do in Sweden, in interprofessional teams where their skills and knowledge are recognized. And we also need to continue, all of us, spreading the message that investing in midwives is not only a health issue, but also a gender and human rights issue. And that message is that sustainable development can only happen when women are healthy, valued, enabled, and empowered to reach their full potential. And as most Swedish women can attest, and research shows, midwives do play a very important role in ensuring this. As far as our development cooperation is concerned, increasing midwifery competence and access to midwives is and will continue to be a centerpiece of our efforts to reduce maternal, newborn, and child morbidity and mortality. Afghanistan, Bangladesh, Ethiopia, Myanmar, Somalia, South Sudan, Uganda, and Zambia are among the countries that have directly benefited from CEDA's support to education and in-service training of midwives. We're also one of the largest donors of core voluntary contributions to WHO and have supported this department for research on midwifery since the 1970s. We're supporting now, as of late last year, core support to ICM, happy to announce, and also have been supporting UNFPA's Maternal Health Thematic Fund for a number of years. So that's just something about our commitment. And again, just thank you so much for inviting me to take part of this launch. And I'm really looking forward to hearing more about how the ECBC's implementation has empowered learners and improved the quality of care for women. Thank you.
Thanks, Sarah. And I think Harriet has sorted out her IT issues. So Harriet Nayiga, who is the ICM Young Midwife Leader, welcome. And maybe you could reflect a little bit also on what struck you from this toolkit. Harriet, maybe you're on mute. apparently still an IT problem. So we'll go to Robin Churchill, who is the Maternal Health Team Lead from USAID. And Robin, over to you to also reflect a little bit on sort of the aspects of the course that struck you, etc. And then we'll come to Harriet.
Great. I'm so pleased to be here, and this is such exciting work. So thank you for including me today. I want to say first and foremost, I am a midwife, and I think that I bring that to all of the work that I do. I think also we all recognize that the world has been turned upside down over the past few years, couple of years, but babies continue to be born. So we need to support and educate midwives who can function in multidisciplinary teams to ensure appropriate, timely care for women and their newborns. And this care needs to be able to adapt to crisis situations, as we have seen. I'm excited about this innovative approach that puts evidence and training materials directly in the hands of midwives, recognizing them, us, as motivated professionals, and supporting our continuous learning with updated educational approaches and active use of evidence. I love the POCQI, the POCI process. I laugh when I hear the name. And I appreciate the value of the mentoring, the support, and that shared learning. I think that's really what is needed. I think it teaches both the what and the how of providing midwifery care. We really need to focus on that how. It's not enough to say this is what you do, but it's really understanding how to do it, weaving the critical care of the whole person, respectful care, the inclusion of companions, addressing mental health needs across the continuum, and promoting midwifery model of care and quality of care for mothers and babies. At USAID, our priorities include respectful care and maternal mental health, and we recognize the linkage there. We also recognize the mental health of midwives themselves and healthcare providers, and that link with respectful care. We understand the very real risk of dying in surgery, but as we work to strengthen the quality of hospitals and surgery for obstetric emergencies, it is critical to simultaneously and with equal focus invest in the primary midwifery management of labor and delivery and preventing unnecessary C-sections and unnecessary interventions. The interdisciplinary midwifery education toolkit is a really important part of this work. We're also super pleased to see that the toolkit includes the care of the newborn through both the essential newborn care content as well as linking to the training materials on the care of the small and sick newborns, the modules in the WHO modules on that. Another focus for us is primary health care and the ability of a provider to integrate and prioritize among multiple health needs and providing multiple services like mental health, family planning, addressing malaria, and working as part of interdisciplinary teams. This is really the piece of primary health care around comprehensiveness as well as continuity of care. Midwives have to be able to do this, and having more practice and thinking about these integrations of care is really important because midwives are the essential primary healthcare providers for women. And as we focus on strong and resilient primary healthcare systems, the innovative approach to learning of the midwifery education toolkit is part of preparing midwives to be active participants in this. Finally, the world depends on well-educated midwives. 100% of us here were born safely. That's why we're here. And our primary healthcare systems require more midwives in leadership positions. I think this toolkit is a really important part of recognizing and preparing midwives as professionals to be active leaders and contributors to strong and resilient systems that can adapt to a rapidly changing world. So thank you. I'm so excited to find opportunities across the USAID projects as well to integrate this. So thank you. Over.
Thank you very much, Robin. And I just wanted to pick on one point made by you and Sarah that, first of all, you have the scope of services, but we also know that midwives stay in their communities and particularly in areas with humanitarian settings. They keep on providing the services and it's really important actually also from a preparedness perspective that we support midwives in their communities. So Harriet, I'm coming back to you. I hope that you are able to open up your camera and mic. And yes, there you are. Over to you.
Okay. Thank you very much. On the representation of International Confederation of Midwives, as the alumni, as the member of the Young Midwifery Leadership program alumni, and I'm very happy for this opportunity. As the International Confederation of Midwives is very grateful for this course because it is going to provide continuing education for the midwives, the practicing midwives, especially around the midwifery practice and focusing on the scope of practice, of course, because midwives really need this, and we love the fact that the course is bringing the partners in maternal health, midwives, doctors, and all other professionals. If they come together, as we look at the content of the course, which is very helpful, like perinatal mental health with respectful care. So we think this is something that is going to improve the care for women, providing respectful, dignified, and evidence-based care. So as International Confederation of Midwives, we are going to support this by disseminating the resource through the midwifery associations and all other networks. So we want to say thank you so much, WHO, and we want to congratulate the team for having come up with this great resource. The midwifery team that has been part of the development of this toolkit. We want to thank you so much. We are going to move it forward. As a midwife from Uganda, I speak racist. We cannot wait to see it to improve the quality of care that midwives and other professionals are giving to the women, children, and adults. Thank you so much. And I'm sorry for my connection.
Thank you very much, Harriet. And we understand the IT connectivity issues. Next, I would like to ask Anna Afuglas, who is a midwifery education lead for Leerdal Global Health and who has been part of the technical working group. I would like to thank you for that support, of course, to sort of reflect a little bit back on this.
Thank you very much, Andrew, and congratulations to everyone who has been involved. And thank you also for inviting Leerdal Global Health into the technical working group. It has been an exciting piece of work, and I would really want to iterate that we have worked a lot on keeping the normal to address the normal process of childbirth, including newborn care. So I will echo Fran's words from time to time throughout our meetings to keep it normal as much as possible. We have a lot to gain for the women, but also for midwives. Also, thank you so much to the Leerdal India Nepal team for the field testing in India. We have learned so much through those field testings, and not only for the ECBC course, but also into the Essential Newborn Care course, and also the Helping Mothers Survive and Helping Babies Breathe courses. So the valuable insights that we have really gained from beyond the ECBC. It has been challenging times during the COVID, and for that, all of you should be commended specifically. The evidence and what Florence West shared about integrating simulation into the course is very valuable for the learning process, not only by the participants, by students, but also for the faculty. So having a good part of simulation integrated in the ECBC is something that we from Leerdal Global Health, and Leerdal has many decades of experience from, and we're very happy to be able to contribute with the simulation part. What we also have discussed a lot in the technical working group is moving it from training into the clinical sites with low dose high frequency and mentorship. So it's super nice to see that the ECBC addresses also low dose high frequency practice into the clinical practice. That is a great help for the midwives, but also for students and their teachers. We look very much forward from Leerdal Global Health and Leerdal to work further with WHO Academy on the digital solutions. We feel like we very much appreciate that partnership, And again, huge congratulations to WHO for all your fantastic work within the field of maternal and newborn health. Together, we are helping saving lives. It is so important that we keep on working together. So thank you very much from all of us. Back
Thank
to
you
you,
very
Andrew.
much. Thank you very much, Anna. And finally, we'll have Janvi Nilekani, who's the chairperson and founder of Astrika. And Mary Ann already referred to the collaboration, but thank you for your support in India. And do you think that as a foundation, you can support the implementation of this toolkit?
Thank you so much. Speaking on behalf of Astrika Foundation, which, as you said, is India-based, we are very happy to support this toolkit for a number of reasons. As a foundation, our vision is a world in which every woman has access to high quality, timely, and respectful maternity care. And we see midwives as critical to that vision, because midwives can address both sides of the public health challenge, both what we call what the Lancet and others call the too little, too late problem of insufficient access to care, as well as the too much, too soon problem of excessive intervention into cesareans, episiotomies, augmentations, and so forth. So we really see midwives as critical to resolving these challenges, and we're very involved with the effort in India to establish a cadre of professional midwives, along with many other partners who are there today. We're very excited to support the WHO in-service midwifery education toolkit. It really uses remarkable innovations in pedagogy and adult learning methods to really create a toolkit for effective capacity building of in-service healthcare workers. It was really wonderful today to see all of the different methods, from treasure hunts to role plays and mentored learning, going far, far beyond the didactic learning approaches of previous capacity building programs. So the other major benefit we see of this program is that this toolkit has been designed for interdisciplinary teams. While we remain fully committed to midwifery along with all of you, nonetheless, there is this huge midwife shortage. I believe 900,000 was the number. And in that interim, while we continue to work on building such numbers of midwives, it's critical that our existing cadres of healthcare providers are aligned with the midwifery model of care, are able to provide mother-centric, respectful maternity care. And a toolkit like this geared for interdisciplinary education is going to be a huge resource both in India and globally. And thank you so much for all the work you do. And Astrika Foundation is delighted to support it.
Thank you very much, Janvi. And of course, this was just the first module of the toolkit that we are launching. And we hope that over the coming months, we'll be adding on the other modules that Alison also reflected on in the presentation. So having said that, I'd like to thank everyone for joining us today, and I'd like to hand over to Elizabeth Iro, who's our WHO Chief Nurse and a midwife as well, for her closing remarks.
Colleagues and friends, I'm sorry I can't be with you in person today, but I am delighted to be able to be a part of this important event and so proud of what has been achieved so far, and with so much more to come. Thank you all for joining this exciting launch. You have heard from the excellent midwifery panel just how innovative the essential childbirth care courses and future toolkit courses will be. This course is a game changer for education, and I thank all those who have contributed to the creation of it. Whilst adult learning should be accessible and stimulating, it should also bring clear benefits for the safety and care of women, newborns, and their families. We have heard that this course is already having an impact on midwifery education, and in turn on the quality and safety of the care that midwives are providing. The potential for real progress across India and globally is both significant and exciting. I want to thank the partners for their continued support, for without us, such improvements in midwifery education are that much more challenging. Your work is incredibly valuable and crucially will save lives. Although this is the close of the launch of the Essential Childbirth Care course, it is just the beginning of the toolkit. We look forward to inviting you to the launch of the next course to be published, the Essential Respectful Care course. I thank you all for taking part today and for your commitment to something very special. Thank you very much.
Thank you very much, Elizabeth. And once again, thank you all. This is the end of the program today. And jointly, we'll be able to implement this toolkit and improve the lives of mother and children. Thank you. Bye.
Thank you. Bye-bye.